Stage. Here I am, Dr. Torrance. I am live at my St. Pete office whiteboard. This is Dr. Torrance. I am waiting on Dr. Zakas to get on here momentarily. Super pumped to answer your questions live. Bringing back the whiteboard live chats. I do have little hands that help me over here and wanted to make sure we got all the people in here today. I think I did this right this time. I didn't do a good job of getting myself in the right screen. Where is this at? There we go. I think we're good right there. Let me kind of slide over here. Hopefully that's good. So I'm here to answer your questions live. Whether it's about craniocervical instability, I'm working on that with Dr. Centeno at this point. Fantastic mentor, somebody that I'm working with to make sure that people get fixed if they're having that bobblehead instability in their neck. Dr. Zakas is going to join me here shortly. We're Regenexx at New Regeneration Orthopedics. I'm Dr. Torrance. It is St. Paddy's Day. Happy St. Paddy's Day to everybody out there who's Irish. I know everybody's Irish on St. Paddy's Day and want to make sure that we are able to produce. I'm going to try to turn a little light on to see if this makes it any better. I always find that this location, I get natural light, but it's not the greatest lighting. So I don't know if that's better or worse. So it might be a little bit better. So I got a little bit of backlighting now. Here I am. I have to give you some billing notes. I'm waiting on Dr. Zakas to get here. And all right. And then Dr. Zakas, where are you, man? I need to see where you're at, dude. Drop some questions in the chat below. I'm happy to answer those. And bye-bye. All right. Dr. Zakas, where are you at, man? All right. Anybody who wants to drop in some questions, ask me some questions. All right. So I've been doing these procedures for almost 9 to 10 years now. So we used to do this. There he is. Add to the stage. Dr. Zakas is here. Dr. Zakas.
How's it going, Dr.
Welcome,
Torrance?
my friend. Hold on, let me see if I can change. Do you like being next to me or would you like to be on top of me? Which one do you prefer?
I don't know. I'm good either way.
All right. I think this is great. So we are here. This is Dr. Greg Zakas. He's our fantastic physician serving everybody in Winter Park. And we are part of Regenexx at New Regeneration Orthopedics of Florida, where we have helped the most patients. I'm probably going to, probably put this before we get the award, 6 out of the last 7 years running, making sure that we're happy to serve people and making sure that they're getting back to doing things they love through image-based injections. So we're here today, Dr. Zakas. Let's throw some questions out there. So what was the case of the week last week for you? What's the favorite case of yours that popped up? And let's talk about it and hash out what we can do about it.
Sure. So I'd say that there was a lot of really good ones, but I would say actually the case of the week is probably a follow-up. I had a patient a couple of months ago. He was a 70-year-old male. He came in. He had about a 75% tear of his supraspinatus, the main rotator cuff tendon. And he was hoping to avoid surgery. He also had moderate osteoarthritis of his glenohumeral joint. So it was looking like if he was going to have surgery, he was going to have a reverse shoulder replacement. Mm-hmm. And he came to me and he said, I don't want to go through a big surgery. I'm an active guy. I just want to get back to what I'm doing. My shoulder's killing me. And his shoulder, he had a pretty restricted range of motion too because of the pain. His active range of motion was diminished, but his passive range of motion was still near normal, which is great. So he didn't have a frozen shoulder.
Yep.
So we ordered an MRI on his shoulders. MRI actually showed he had quite a bit of bone marrow edema underneath the supraspinatus tear.
Okay.
So in his particular case, I elected to use bone marrow aspirate concentrate as well as micronized fat.
Mm-hmm.
So I injected the fat into the rotator cuff tear itself, as well as some of his body's own stem cells and other healing cells from his bone marrow concentrate. And then I also did a intraosseous injection of the bone marrow aspirate concentrate into the bone marrow edema that was underneath the supraspinatus tear. So I saw him back in follow-up 2 months last week, and he's already 80% better. He's super happy. He's having a lot of neck pain and periscapular pain because of the lack of range of motion in the shoulder, and that's gotten better as well. So yeah, so 2 months in, he's already 80% better. He's super happy and super satisfied. And I told him, it's likely that we're going to continue. 8 weeks is still kind of the beginning of the healing window. And so he's likely to get better from there. So he's going to keep up with his physical therapy. We're going to talk again in 6 weeks and see how he's doing.
So what I'm drawing here, I hope you can see it here. So what I'm drawing is the supraspinatus insertion on the rotator cuff. And what I want to do is I want to draw these things so that people understand what we're looking at. So hopefully you guys can all see that here. And so when you look at this, where he's talking about injecting and where, so what we do with the ultrasound guidance is we're injecting into this space right here. This is your supraspinatus tear, okay? There's usually a little bit of like an anechoic area, like right in here. And the edema that he's talking about is usually right in this area here. Is that about where it was at?
Yeah, exactly. Yeah.
And so when we inject into the rotator cuff, we're injecting into the rotator cuff to help get that to kind of glue itself back together. But a lot of times it's pulled itself out of this insertion here, okay? And that creates some inflammation and edema. So by injecting precisely into the right spot that you see on MRI, it looks like this. We can use the ultrasound to guide that there. And then we also use fluoroscopy or live x-ray to make sure that we get some good flow into this bone. 80% at 8 weeks. I've seen this before. They're going to be 90% plus, feeling fantastic. They're probably going to forget the shoulder even bothered them at about 12 to 16 weeks. So fantastic case. I think that's a good one to kind of talk about. And the next stuff, there might be in 25% of shoulder issues, there's some underlying cervical issues that might have been the trigger or the cause of this root cause. So that's something really to look out for. And I hope you kind of coached him up on that. I'm sure you did. You're the interventional spine guy. So, I just want
we talked about that. I got him. I was pretty convinced that the shoulder was the main issue here. Yeah. And so I said, let's give this 3 or 4 months. Yeah. And if your neck is not better, then we can evaluate that then. But it's already feeling quite a bit better. So we'll have to see if he actually needs to have that evaluated or not.
Fantastic. Awesome. So hot topic for me. So I've got a posterior tibial tendon tear coming in this week. Oh, they tried about everything else that they could, still having that posterior tibial tendon issues. Please, folks, don't let your sports medicine doctor inject steroids into your posterior tibial tendon. It's not going to be good for you, and it might cause you to have more issues in the long run. So that's my little factoid and clinical pearl of the day. But I love shoulders. I had my shoulder done in 2017, and my right shoulder doesn't bother me anymore. My left shoulder is probably my bugaboo. All right. So what else? So let's talk about the course we had. We had the course 2 weeks ago. It was a fantastic course. Everybody did fantastic. We had live. We didn't have live. We had live models, and then we also had cadavers to make sure that we're working and doing these procedures to the best of our ability for our patients. And so, Dr. Zakas, you want to explain what the cadaver provides that you can't do on a live model, and kind of just give that out there to the people in the audience?
Sure. Yeah. It makes sense to first practice on a cadaver, because if you're doing something new, because the cadaver doesn't say ouch and the cadaver doesn't feel any pain. And it just gives physicians an opportunity to kind of take their first swing on a human body part, but it's on somebody that's not alive. So there's very little risk there. So what I noticed from most of the student doctors who were learning there was that it just increases their confidence, just to know, like, oh, okay, like this is kind of what it's like. This is what it kind of feels like. And the truth is that a lot of times, and and I think you'll agree with me, Dr. Torrance, a lot of times it's actually easier to inject on a real person than it is on a cadaver because we just get kind of like the part of the person, the cadaver. And so positioning and getting things, and then under ultrasound, the tissues don't look quite normal because a lot of times they're quite dehydrated.
Mm-hmm.
And so it's actually more difficult to inject on cadavers sometimes, at least at first. And that was what a lot of the, in the group that I was in, which was knee and hip, that's what a lot of the student doctors were saying. It's like, oh, this is like difficult to get this to hold up straight or maneuver or not fall over. So this has been the way it's been for decades and decades in medicine with interventional and surgical procedures. And it's just a great opportunity. And IOF does a really great job, great instructors. And it was fun to have our clinics host the event too. It was like, it was kind of like playing a home game is the way it felt to me.
Yeah, definitely home field crowd, home field teachers, and definitely agree with you on the cadaver is not the same as a live patient. Mm-hmm. They don't hold themselves up as well. They're dehydrated. They didn't drink well that night before. They came in with all the problems. So you can inject a cadaver, you can inject anything, and the fluids, natural fluids in the joint that you're trying to utilize, especially in knees, right? Mm-hmm. You'll see there's still the fluids are kind of they're all dehydrated. So 100% a cadaver model is not it's not perfect. It makes it harder, but which it makes injecting a real patient easier, which is good for everybody, and everybody wins there. So that's fantastic. So I think that was a great course. It was knee and hip, and then it was shoulder and elbow, and we got plenty of reps for everybody doing all the injections that we need to do to make sure that everybody does these injections the right way. And that's something that really brings up a great topic, is that if somebody is not using ultrasound or fluoroscopic imaging to inject you or a loved one, please respectfully walk out of the clinic and go see somebody else, whether it's us or somebody else. It is below standard of care, in my opinion. I think of anybody's opinion who does interventional injections to do these without guidance. You're going to miss a lot more. I think the AC joint study was like 25% of the time you're getting in the right place. And then the knee lateral suprapatellar recess is, I sit there sometimes and I'm doing these injections and I'm like, how does anybody get in the right spot without ultrasound? It's like impossible. So I think that would be my big takeaway, is make sure you see somebody's using guidance. And what are your thoughts on that? I mean, like, Dr. Zakas, you're new with us, and like you've had a lot of real world experience. How many people are actually using image guidance besides our clinic and the select clinics that we know and care, the people we know and work with all the time?
So obviously, pain doctors in general are using fluoro for spine procedures. I would say, gosh, it's hard to say how much. Very, very few of them have any ultrasound skills, and if they do, they're just doing simple stuff. There was a doctor from a group I was friendly with back in Arizona, where I lived before here, and they do some injections in ultrasound, but they don't have any good diagnostic ultrasound skills. And so, that's a whole other can of worms. It's like, well, how do you even know what you're injecting? A lot of times I find small rotator cuff tears that are missed on the MRI. So how do you even know to inject if you can't diagnose where the issues are? But I'd say very few. There's very, very few doctors in the country and even in the world who have the complement of skills that we have at New Regeneration Orthopedics of Florida. Very few. Some people are really good at spine. Some people are really good at joints. Very few doctors are good at both, though. And that's what we do. And I think that's what makes us different. Is I was over the weekend, I went on a kayaking trip. And of course, everybody's got something that's sore there. And I love talking about this. So I ended up talking about, to the tour guide and everybody else. And, I told the tour guide, I said, we treat every joint, from the TMJ all the way down to your toes and everything in between. If there's ultrasound imaging, there's X-ray imaging, we can hit it. And so very, very few physicians in the country and in the world can actually do this at a very high level, both spine and joint with ultrasound.
100%. Great statement. I'm going to pivot to this question. What area of the body would you say responds best to your procedures? Dr. Zakas, you go first and I'll go second.
Okay. I would say all of them.
That's a politician's answer. Give me one.
Really, you know what it is, but it's the truth. And the research, not just our own internal research, but the Regenix research over 20 years shows that if you can identify where the problem is and you can inject it with the correct solution made from the patient's own cells, then a large majority of the patients are going to get better. Mm-hmm. So, I've seen great success everywhere. I mean, there's certain things where it's particularly gratifying. The worse the patient's condition is and the better they get, that's particularly gratifying because they go from almost disabled to being able to do most things that they want, versus if they just have something that's kind of nagging. We still get that better too, but the difference in the function isn't as great. And so I'd say in general, when you're seeing these cases with these severe like knee osteoarthritis cases, and they're getting better with intraosseous injections, like that's a favorite one for me. But again, it's just because of the difference in function that you see versus somebody who maybe has a little ankle pain or a little knee pain or a little tendinopathy. It's like they can still do everything, but it kind of hurts. Those are still great, but those don't stick with you as much because they are already kind of doing everything and they just want to be able to do them pain-free. But yeah, this works everywhere. A tendon is a tendon is a tendon. And a ligament is a ligament is a ligament, and a nerve is a nerve is a nerve. And so this stuff works really great everywhere.
Yeah. I personally think one of our sweet spots and one of the biggest things that we can really help patients with, this is what I'm doing tomorrow. I'm doing a bone marrow procedure for a partial tear of a tendon. And I think that those really respond very well because not only do we get the inflammation to resolve and the pain gets a lot better, but we also do see true healing. And that's something we can kind of hang our hat on because of our rotator cuff study that showed that we had tendon healing in 73% of MRI follow-ups at 2 years. That's bone marrow concentrate for rotator cuff. That's Centeno et al. And so that's really one of the ones I think that's a sweet spot because in the traditional orthopedics, all you have is a steroid injection and you have surgical intervention, right? And when something's a partial tear, and that's something that I always like to talk to patients about, and I'm gonna pivot to the whiteboard again, is because when a tendon should look like this on ultrasound, right? And a lot of people, I think, when they hear tear, they really think that a tear is this. It's completely through. Okay, there's no black and white. It's black and white. That's a complete tear right there. And so that's one of the things that I think that really has a lot of nuance and a lot of variability that we don't really talk about enough. Is that it really there's things. So let's put this tendon back in place here. And so a partial tendon tear, what is that? Well, that's something that looks like this. So we have really good tendon above it, but we have a 50% partial thickness tear. And I think that's where the sweet spot is for regenerative orthopedics and especially image-guided injections, because I need to inject precisely into that spot here to fill that spot up with your body's own cells. And that's where I think that the sweet spot is for what we do. So that's one of the things I get super excited about. I think tendon, partial tendon tears. I also think that our knee arthritis, like you said, the interosseous injections are a game changer for arthritis patients who are trying to avoid a knee replacement. Felipe Hernigau's study that looked at a 15-year follow-up on these interosseous injections showed that 80% of patients, I think it was 82% actually, so 8 out of 10 patients avoided a knee replacement 15 years later, guys. So if you're 65 and you want to avoid a knee replacement, perhaps the rest of your life, I think that's a fantastic option, and I think it does great for patients. So those are two things that really get me excited and responds best. But I do the politician answer as well. Everything responds great, but we also know our limits and our limitations, and that's what you're going to get from any of the physicians that you work with at Neurogeneration Orthopedics of Florida. We're going to give you an honest assessment. We give you an hour-long consultation. These are some of the differences between us and Joe Schmo down the street. They're going to get you in and get you out, maybe give you 5 minutes. And they're going to go, oh, well, this is what we think. And order an image and never review it with you or something along those lines. They have to review it with you, but that's really one of the things. But yeah, something that I really think is good. Trying to ping the audience.
Can I interject for a second, Doctor? You said two really important things that I just want to expand on a little bit. Number one, if a patient has severe osteoarthritis of like a knee or a hip or a shoulder, and their orthobiologics, their alleged regenerative orthopedics physician is not doing intraosseous injections, they are robbing that patient of what is now the standard of care in orthobiologics for severe osteoarthritis. So that's something I really hit home to patients. Is a lot of people dabble in this, or maybe they'll put some MFAT in or to the joint, or they'll put some BMAC into the joint. And I tell them, look, if you're physician is not doing the intraosseous injections, they're not giving you the best treatment that's going to give you the best chance of avoiding a joint replacement for the long run. So that's the first point I want to hammer home, and I'll let you draw there.
Yeah, keep going. So talk about the interosseous injections. I'm going to draw there. I'm trying to make sure it shows up on the right screen here.
Okay, for sure. Yeah, so intraosseous injection is kind of what the word says. So that means into the bone. And so what Dr. Hernigau did in his studies of hip and knee was inject the lion's share of your bone marrow aspirate concentrate, which contains your body's own stem cells and other healing cells, into the bone surrounding the joint. And in the case of the knee, it's usually on the worst side, in the upper bone, which is the femur, and the lower bone, which is the tibia. And sometimes we have to inject into the patella, the kneecap as well.
Yep. So I'm working on this here.
Yeah, that's great.
So this is the knee. This is where the bone marrow edema most commonly is found. Okay, in these areas here. And so the kneecap kind of lives right here, kind of a little off center, usually to the lateral side. This is the lateral side because of the fibula. And so this is where we usually will see a lot of the bone marrow edema. And that really is, it's a game changer. It's thinking outside the box. It's really thinking about, okay, if we just change, I give a lot of analogies for this, but if we just change the struts on a car, and don't change, there's a lot of, that's a bad analogy. I hate that analogy. But I'm trying to think of I use so many good ones. Nope, don't have one right now. But yeah, so injecting the bone, getting things better from the inside out, is really the biggest thing here. It's like putting lipstick on a pig. If you put lipstick on the pig, but you don't get the pig healthier, give it good food, all that kind of stuff, it's never going to get better. So making sure that you're treating things from the inside out. And also, we also will inject into, if you have the meniscus tear, right? It's probably a degenerative meniscus tear. If you got this bone marrow edema, we'll inject into the meniscus itself. We'll inject the ACL if there's some laxity, and then onto the cartilage surface that might be thin too. So really getting all those positions at once is going to give you the best and best outcomes to stabilize the knee, stabilize the structures, and go from there.
Right. So the bone marrow lesions, they cause pain, and typically when somebody is needing a knee replacement, once they get to that point, it's because of the pain that's come from these bone marrow lesions. And so there's also some MRI evidence of these being healed after people have these injected. And so even if not large amounts of cartilage are regrown in the knee, because nothing has consistently been proven yet to do that, by healing the bone marrow lesions, by resolving that inflammation, patients get unbelievable pain relief. And if you can get these to go away, it leads to a healthier cartilage bone surface anyways. But the healing of the bone marrow lesion really is likely the game changer in what's getting these patients better.
100%.
The second thing I wanted to mention that you said before is, I'm glad when you're talking about rotator cuff, you were saying about how, we do have MRI and ultrasound evidence in some cases of the tissue actually healing itself. And we also have ACL case studies of the ligament being regenerated as well on MRI. And I want to mention that because there's some, famous people on Instagram and the internet who are going around saying, that your own cells are only anti-inflammatory. They don't actually grow new tissue. And that's absolutely false. What they're referring to was Dr. Kaplan's studies on rabbits and smaller animals, where he was using cells from other animals because they couldn't get enough from the bone marrow from them. So yes, if you take someone else's cells and put them into your body, like if you go to Mexico or somewhere like that, and you have allogenic stem cells from an umbilical cord from someone else injected into you, yes, those cells themselves will not integrate into your tissue. They may be anti-inflammatory. Your immune system is going to clear them up quickly, but your body's own cells will stay and play where they're injected. And that actually can lead to healing of tissues. So that's a really important point. Because like I said, things go on the internet, they go viral, and people are saying that your own cells are only anti-inflammatory, they don't heal anything. That's absolutely false. Your own cells will heal you better than somebody else's cells. And every bit of research that's available proves that.
100% accurate. I agree with everything you say. The one thing I would add and caveat to that is that there also is the rejection capability of somebody else's cells. And that becomes a question mark, whether that's going to actually cause more inflammation and cause more pain and could cause some other sequela of symptoms later on. So
and nobody knows because it hasn't been studied enough in humans.
No. So one of the things that I got tasked with talking about today is, I believe we have a plantar plate discussion.
Oh, cool.
I've seen plantar plates do fantastic. And what is a plantar plate tear, and how can we help it? So when your metatarsal phalangeal joints, that might be called metatarsalgia, plantar plate, it's usually, if somebody has an ultrasound, is able to look at it. The plantar plate is the area on the insertion of the foot. And so again, you kind of look at your toe here, trying to draw some structures. But as it kind of comes in here and inserts, it's where that toe comes out like this. How's it looking? It's right here on this insertion right here. And so it's a very, very tough injury to treat. It usually is misdiagnosed as metatarsalgia. And the best way to do this is to look at it with an ultrasound and then use PRP versus bone marrow concentrate, depending how severe, how bad, and what's going on to get the best outcome. But it would be this portion right here on the plantar plate where that happens. Okay, so that's a plantar plate injury. We can get it better by using orthobiologics with ultrasound guidance and go from there. So that would be that one. Hit that topic today. Boom.
And this is called turf toe in the athletic world, correct?
That's true. So turf toe, turf toe is one of the, it's the big toe. Now that can be on any toe, is the one that I showed you there, but absolutely, it's called turf toe when it's usually on the great toe. All right. Let's see. We're trying to do this for 30 minutes every other week and trying to stay consistent with this. I want to make sure that we talk about anything that might be top of mind. If your head feels like it's on a bobblehead, you might have CCI. Right. If you have some brain fog, you might have CCI. If you have TMJ, that's also a symptom that he mentioned TMJ earlier. From TMJ down, a lot of times TMJ is associated with craniocervical instability. That's something that I've been working with Dr. Centeno to bring to the state of Florida here in the next few quarters. We're just making sure we cross our T's and dot our I's with all the setups and everything we need to do with that. So that's coming soon. So Dr. Zakas will be doing that with me as well. He's a fantastic injector of the upper cervical already. And we're just making sure we're doing all the right things and learning all the right stuff, because Dr. Centeno is the only guy who's done over 1,000 of those injections and has plenty of outcomes data to talk about. So craniocervical instability, if you don't know what that is, don't worry about it. But if you have brain fog, headaches, bobblehead symptoms,
gastrointestinal symptoms.
What?
Gastrointestinal symptoms,
swallowing issues. Let us know, and we come in for a consultation. If you don't have a DMX image yet, get one. It might show and demonstrate where it might give you some objective data, what's really going on with your craniocervical instability. And these are things that not a lot of clinicians look for. And we're here to help you in those situations. So something that Dr. Zakas, you want to kind of chime in on that at all, or anything
Sure,
else?
yeah. So a small fraction of patients who have neck pain, cervical spine issues have CCI, have craniocervical instability. And what that basically is when the ligaments are damaged that attach your neck to your head. And so like Dr. Torrance said, that can present in a number of symptoms, because when this area is off, the brain stem is there, the vagus nerves are there, the internal jugular veins are there. So there can be a wide variety of different symptoms that are caused by that. So I'm really excited and looking forward to learning how to properly treat this condition and bring that to Florida.
And I'm going to do probably a butcher this, but it's, it's kind of like.
Is that our solar system there that we're?
Yes, the solar system. This is Saturn. But no, this is the atlas surrounding the axis, right? Trying to get you a decent drawing here. And so one of the most common things that this little, joint right here, the C1, C2 is one of the biggest areas right in this area. And then you have your crane. That's just not. That's a tough one to draw, man. You gotta go
you'll have plenty of practice though in the future.
Yeah. So, but you got the other stuff around here. I'm done. I'm stopping that. But no, those are some things that we're coming soon. But come see us for a consultation now.
Torrance, next time, I think, because baseball season is starting, we should talk about ulnar collateral ligament injury, since this is like Tommy John season, right? And if these things aren't completely torn, a lot of times we can inject these. Actually, I have one coming up this week. I have about one a month now. Ulnar collateral ligament tears, and so that should be something maybe we should focus on next time we do this.
100%. And go Team USA against Venezuela tonight. Don't want to get too much into politics there, but go USA. But anyway, so yeah, if you're not watching the World Baseball Classic, check it out. The Team USA takes on Venezuela tonight. USA beat the Dominican Republic 2 nights ago on a very well pitched game by Paul Skeens, former Air Force grad, and had a great game, and the ending was pretty fantastic. Whether you call it, I think it was a strike or not. I think the strike zone moved, to be honest with you. Yeah, it seemed like it's all of a sudden moved up, and like I was like, that pitch was a lot better than it looked on the zone. So hey, the ABS doesn't exist yet except for in Major League. So if you're not following baseball, you don't follow this. Don't jump in. But yeah, so yeah, we'll definitely talk about the UCL. UCL injuries are definitely fantastic options for us. Again, talking about things that are partial tears that respond well to our procedures. Tommy John injuries are Tommy John injuries. Tommy John was the first the pitcher who had the surgery. I think it was done by Dr. James Andrews, unless I'm wrong. I think he's the one who started it, or maybe Job. I have to look that up. I don't know that answer, to be honest with you. But that was the first surgery to really connect the anterior band of the ulnar collateral ligament. And so if it's not completely torn, why replace it? Why do something to it? So we can do things like PRP or bone marrow concentrate injections to help get it better. So we'll talk about that next week or 2 weeks from now. Let's do 2 weeks. And bring questions. If you missed this, we're going to post this. We're going to post some comments. Jump on there. Sarasota, Tampa, St. Pete, and Orlando. We're servicing. Hey, if you're in the state of Florida, there's a close enough place to come see us. We see patients from England. We see people from Australia. We see people from all around the world to help with these types of injections. We're the best at what we do, and we were grateful to have you for a consult. We can even start with a virtual consult to just look at your images, discuss things, see if you're a candidate or not. And if not, then we can definitely point you in the right direction. So, Dr. Zakas, thanks for joining me tonight. Anything else you want to add before we sign off?
No, I'm good. Thank you so much, Dr. Torrance. I appreciate it.
All right, brother. Talk soon. Have a great night. All right.